So it's time for us to get started. Today we have a special speaker, one of our own, Dr. Maz Sahai, who's our chief resident, came to us from Florida Atlantic University, where he did his residency, and he's been our fourth-year chief resident for the past 9 months now, and really done a remarkable job in terms of elevating the teaching program and interacting with the residents, and we're just thrilled that he's here, and I'm even more thrilled that he's going to be a gastroenterology fellow next year starting, and so you better get some sleep now. And but we're thrilled to have him come and join us, and he's going to be speaking today about hepatorenal syndrome, what it is and where we are. So let's give him a welcome. Thank you.
All right. Hello, everyone. So unfortunately, I have not practiced medicine in the White House or been across the country, but since residency, and I'm only about a year out, I have seen quite a few patients that obviously are not only cirrhotics, but have had some form of kidney injury, and that may be hepatorenal syndrome. So while I was looking for what kind of topic to kind of cover here, I ran into this article, and I stumbled upon an article which kind of reviewed really all the new stuff that's been going on in this field in the Journal of Gastroenterology and Hepatology, and this was published about last year. So there's a lot of new stuff over the last at least 5 to 7 years that we're kind of going to go over and really understand, what exactly takes place in the body when we think of hepatorenal syndrome. We've had many different theories before into the pathophysiology of this, and then there's certain changes that various organizations have kind of come up with to help explain and really to help treat this, because this is a high mortality diagnosis. Previously reported the survivability of these patients when we said type 1 hepatorenal syndrome, not more than a month, type 2, like a few months, 3 to 5 months. So let's get started. So the goals today, obviously we want to understand what exactly it is and how we diagnose it based on the new criteria. We want to evaluate renal dysfunction in these patients, and that's really the crux of this, because that evaluating renal dysfunction is the challenging part, and I'll get to that. I'll get to why that is, as well as renal biomarkers that help us identify acute kidney injury in cirrhotic patients, because it's tough to use the same type of markers as we currently use for otherwise normal healthy patients. And the pathophysiology leading to the hepatorenal syndrome. This again is over the years we've kind of changed our theories of where this is coming about. And lastly, obviously the treatment options we have available for hepatorenal syndrome, and hopefully I'll be able to do all this in about 45 minutes. All right, so being on the other side of many of these lectures, I have a very short attention span to begin with. And I don't like to put a lot of words on my slide. So I'm going to try to talk through a lot of this. And to really sum up kind of what's been going, I think it's interesting where we see how far we've come. The field of medicine, each year, we're kind of reaching new peaks in terms of all different types of specialties. And it's really cool where we are, because years and years and decades of research have gone into these things, which I'm just going to sum up in about 45 minutes. So in about the 1800s, we really started to see scientists and medical specialists, they started describing this type of this renal failure that was occurring in the cirrhotic patients. This was in the late 1800s. A guy by the name of Flint started doing autopsies on cirrhotic patients and realized you can, when they did when they checked the kidney, histologically there was nothing wrong with them, even though these patients while living had renal disease. Then in the early 1900s, HRS was first described as renal failure after some type of biliary surgery or trauma, which is obviously not the current definition we have. And by the mid to late 1900s, this started getting characterized as what we kind of know now, which is, low urinary sodium, progressive oliguria, and no proteinuria, meaning like there's no intrinsic renal disease really going on here. It's as a result of the portal hypertension that takes place in these cirrhotic patients. And by the early 70s, there's different reports where they transplanted the kidneys from the cadavers who had cirrhosis and renal injury, and they showed that the renal injury was reversible. And in another study, they did a liver transplant and showed that the renal injury was reversible. So really, what caused all this kidney injury was not the kidney itself, as we said, not intrinsic kidney disease, but really all the systemic things that are going on leading to low perfusion and vasoconstriction in the kidney. So this is from the 1970s, and even then, as you can see in image A, this is a cirrhotic patient with renal disease, with AKI, hepatorenal syndrome, and you can barely make out the kidney. This is the main renal arteries coming in. You can barely make out the kidney here because it's so vasoconstricted everywhere. This is an angiogram post-mortem, and you can see that really there's nothing histologically, as we mentioned before, wrong, as it really perfuses pretty well. So it's really the kidney that's in the setting of those cirrhotic patients going through those inflammatory markers and those vasoconstrictors that's causing this type of AKI in these patients. So in 1996 is when we have like the real criterion definition for hepatorenal syndrome, and this is what's kind of been looked over, and they just republished this in 2005. They met again and changed this. So at that point in time, we still wanted to volume expand these patients to see if there was any pre-renal disease, to see if this wasn't really HRS, this was just hypovolemia, essentially, to the kidneys. And back then, they used isotonic saline. Obviously, now we use albumin, and we'll go over that. There was obviously absence of gastrointestinal renal losses, and you obviously need to have an absence of shock, bacterial infection, nephrotoxic drug. So you want to rule out these other causes, which hasn't really changed. The low GFR here, we don't use micromoles per liter, we use milligrams per deciliters mostly, and this is basically equivalent to 1.5 creatinine that we see. And that's really the thing that's going to be changing, and that has changed now. This additional criteria, we'll go over, but it's essentially been done with because it's not really been tested in cirrhotic patients. All right, so essentially to understand where the new definition comes from and how we really understand kidney injury and GFR in cirrhotic patients, we kind of need to know how we evaluate this, right? Our most basic and most used way to evaluate GFR is essentially a spot blood creatinine. Now, in otherwise healthy patients, that may be fine, but in patients who are cirrhotic, that's really troublesome. And that's because most of the creatinine comes from a non-enzymatically converted, and it happens in our muscles. And it starts with the liver and the stuff we eat, like meat and proteins. That goes into our muscles, and that is excreted and filtrated by the kidney, and that's how we measure this. Now, the problem is the creatine, which is the precursor to creatinine, is already so low in patients in liver disease. And that's been shown multiple times. And you can see in normal population, you have essentially creatine almost at 1.2, and it's almost half in patients with liver disease. That's liver disease with portal hypertension and without portal hypertension. So we kind of see why that is. And because of all the things that are going on in patients with cirrhosis, you see this drop in creatinine. You have about a 50% drop in creatine production just because of the cirrhotic liver, because the liver is not producing your creatine. The ascites allows for the volume expansion and the diffusion of this of the creatinine, also lowering that. And lastly, the decreased muscle mass. There's not many cirrhotic or end-stage cirrhotic patients you see that really have a decent amount of muscle mass. They don't have as much muscle mass as the normal population, and they don't eat as much as the normal population, partly because of the ascites, because of the early satiety. All of that means that they actually have a much lower baseline creatinine, and the creatinine may not be red, like red or black or bold when we're looking at these labs, but these patients may be in profound AKI by the time we even see them, even with the creatinine of about 1.21. they can have a creatinine of 0.4 at baseline, and it can be much reduced from when they were healthier. So an increase in creatinine from 0.4 to 0.7 or to 1 is a huge increase in their actual creatinine, and that just means that how much of a kidney injury they have, whereas to us, it just is normal value. So all this essentially leads to a total decreased creatinine, and this is my attempt at somebody who's jaundiced. The other thing is that hyperbilirubinemia, the way we measure creatinine is by something called the Jaffe reaction. And if you have high enough bilirubin, it actually interferes with properly measuring creatinine, and it gives us a falsely low creatinine on top of that. So there's so many different things going on that really cause these patients with liver disease, especially end-stage liver disease cirrhosis, to have a much lower creatinine, and we can't compare or we can't associate the same with a normal patient. And on top of that, what they have shown is that not only is the creatinine lower in these patients, it's actually delayed marker of GFR even by up to 3 days. So in cirrhotic patients, it just takes time. So, really, can hepatorenal syndrome now be present if the serum creatinine is less than 1.5 as it was previously described? And yes, a lot of the diagnoses were presumptive diagnoses because they didn't really get up to 1.5. By this point of time, they already had such profound AKI that everybody was thinking, what if we had acted earlier? What if we had given them albumin earlier? Maybe we would have had a chance to reverse this process. So that's what led to this current criteria by the club, the International Club of Societies, in 2015. And really now we are changing the way we look at it. We did away with the minor criteria because that's really not been studied in the cirrhotics, in the cirrhotic population. And the other part of the definition essentially stays the same, right? We want an absence of intrinsic kidney disease. We want an absence of ATN. We want to rule out all the other causes, including nephrotoxic agents, NSAIDs, and so on. You want an absence of shock. And you want to try to volume expand these patients to make sure that they don't have any pre-renal azotemia that you can actually fix. And before we used normal saline, and now obviously we use albumin, which is much better. We'll go over that. So this AKI now is not a set value for creatinine of 1.5. It is really the overall increase from their baseline creatinine, which, as agreed by these various societies, is now a creatinine increase in 0.3. So just 0.3. So again, if you have a baseline creatinine of 0.4 and this goes up to 0.7, we see it as a normal value, but that's AKI. That's straight up AKI in patients who are cirrhotic. So over 48 hours, or an increase in creatinine by 50% over a course of 7 days. Okay, so really now we're moving away from that single creatinine value, right? We want to identify these patients earlier. And this has to be, was agreed upon, the definition of our acute kidney injury is essentially agreed upon by these bodies. And the other thing that's really changed is we want to identify the kidney injury before we really think about hepatorenal syndrome. Yes, it's in the back of our mind, but we need to identify acute kidney injury. More importantly, we need to identify the stage of acute kidney injury before we even get to that hepatorenal syndrome. So the progression of AKI stages is important because obviously if you have higher stages of AKI, that leads to higher mortality rates in patients who have cirrhosis. So types of HRS. When I was in med school and even in residency, we still use hepatorenal type 1, hepatorenal type 2. Type 1, type 2 is diuretic refractory. Type 1 is more of an acute onset. Now we have a little bit of a different definition, and that is hepatorenal syndrome AKI type and hepatorenal syndrome CKD type, which have replaced really the type 1 and type 2 nomenclature. And the reason is because we see this more of as a spectrum of kidney disease that happens in these end-stage cirrhotic patients. AKI, obviously any acute kidney injury over the course of time, and CKD by definition has to be greater than 3 months. So this whole spectrum can be taking place while these patients are otherwise walking around, living at home, following up outpatient, and it's really up to the outpatient physicians, whether it be GI, nephrologist, internal medicine, family medicine, to really see that change from baseline creatinine and see it creeping up, because already we may be able to see and identify this hepatorenal CKD type syndrome. And obviously AKI would be any abrupt change which can be brought on by bleeding, large volume ascites, sepsis, etc. So this is now the way we view hepatorenal syndrome, AKI and CKD. Okay. So measuring GFR, as we just talked about, is very difficult in these patients using creatinine. And ideally, we would love to use something as inulin or iothalamate, which really is how we kind of, double check our GFR in all these studies. But that doesn't really happen. It's expensive, it's time consuming, it's not available in all facilities in most hospitals. We can do creatinine clearance over time, but again, that's time sensitive. And the other issue is most of these patients are oliguric or anuric. So, but it's still important to identify renal function. And part of the reason is when we really look at the end-all treatment for this, which is transplantation, because the initial injury starts with a cirrhotic liver and portal hypertension. These, the liver and simultaneous liver kidney transplant decisions are made by the creatinine of these patients, because the equation that goes into finding out if they're good enough candidates for transplant is a creatinine-based equation, which is the MDRD6 equation currently. So now a lot of research has been going on to, okay, what are the other ways we can check appropriately the GFR levels in these cirrhotic patients? So cystatin C is a pretty cool marker. It's a protein that really is independent of hepatic function, which is great in cirrhotics. It's independent of age, essentially. It's taken into account. And the last thing is independent of gender. And I'll go on to show why that's important as well. So this is something that there's been numerous studies coming out, and in the future may be used in patients, especially in cirrhotics, to measure GFR more appropriately. Okay, so we talked about how overall cirrhotic patients already, we can't identify their GFR properly just by using creatinine or creatinine-based equations. Well, there's also a difference between men and women. There's also a difference between the races. So if you look here, for example, at a GFR of 60, men usually have a slightly higher creatinine than women at baseline, just usually because of the muscle mass and everything like that. But as you get lower, as this GFR comes down and you have more renal dysfunction, you see that the confidence interval essentially separates. So it's even harder to identify appropriately where their GFR is just based on creatinine. So a GFR of 0, for example, in women, in Caucasian women is between 4 and 5. Here you have almost 7. So those numbers somewhat seem different to us when we're looking at them on a chart, but they both essentially have a GFR of 0. And the same is true between black men and black women and white women. And what does this mean? This means that, and we've shown this, so because of the creatinine-based equation, because the level of creatinine goes into finding out whether you get liver transplantation, they've shown that females have a much higher mortality when you compare them to men of the same level of liver disease when it comes to waiting on that transplant list. So that's another reason we really need to figure out what's the best way to measure GFR in these patients. So how did we start getting into measuring GFR? Well, all these creatinine-based equations and even the cystatin C equations were measured and not studied in cirrhotic patients. They're mostly measured in either normal patients, CKD patients, but most of them are not cirrhotic. So a lot of scientists and researchers, got to the task of putting these equations to the test on cirrhotic patients. And we then had to, basically separate our patients with cirrhosis into these 3 categories, which is essentially sequentially, as you can see, the GFR goes down when you start with pre-ascites, and then diuretic sensitive ascites and diuretic refractory ascites. As we know, this is the progression of liver disease and cirrhosis. And these are really, this table kind of sums up on how much this has been studied in the different types of equations. So on the left, we have these creatinine equations originally studied in most patients with CKD. In 2017, studied in cirrhosis, which showed a better measure of GFR, because now we're actually studying the actual population. Then we have the cystatin C equations. And then lastly, we combined this cystatin C and creatinine equations, and that really showed, and especially in cirrhotic patients, that they're a much better predictor of GFR in these patients. So in the coming years, hopefully we'll see some form of these equations, including cystatin C, and that will give us a proper evaluation of really where their GFR is. And if that happens, we can really identify when this kidney injury starts to happen and be able to intervene in a much faster way and hopefully increase at least their quality of life. So this, in 2012 and 2016, really, they first tested these equations on cirrhotic patients, and then they specifically derived equations for the GFR from patients with cirrhosis. So quite a bit of research going into this. This table really sums up how we go on evaluating if somebody has hepatorenal syndrome. So I showed you the 2015 guidelines of diagnosing it, and this is really where it starts. You want to always make sure we know their baseline creatinine, and we always make that extra effort, even in the hospital, to follow up with the primary care physicians, to follow up with whichever physician, whether, not a lot of people are from Tennessee, sometimes they're from Georgia and other places. We really want to try to get a baseline creatinine on these patients because they may already be in AKI. So if we see a greater than 0.3 increase on admission within 48 hours, we already know they have AKI. We don't have a baseline creatinine, we can just consistently measure the creatinine, or obviously if we see a decrease, we know that the AKI is resolving. And again, before the diagnosis of HRS, we need to make sure we identify the stage of AKI. That helps us in not only figuring out if they need dialysis, but really how fast this AKI is progressing. And lastly, we want to stop all diuretics, vasoconstrictors, nephrotoxic drugs, and see if that improves the kidney function. We want to treat any infections, we want to treat any other diseases that are going on, and we want to challenge them with volume expansion by using albumin. If all that fixes their problem, still, we're not at hepatorenal syndrome. This is not hepatorenal syndrome. If none of that works, then we start to evaluate for hepatorenal syndrome or some other forms of AKI. And when we have finally made the diagnosis, or we think we have made the diagnosis of hepatorenal syndrome, then we go on to treat them. And we'll go over that at the end. Okay, so AKI and cirrhosis. Patients, obviously, who respond to volume treatment are going to be in prerenal azotemia. We have already essentially fixed them or are trying to fix them. Patients not responding to that, we still have to look for these intrinsic renal diseases, ATN, glomerulonephritis, AIN, and any post-renal etiologies, including obstruction. Aside from HRS, there's a lot of other things that can go on. Somebody with a lot of ascites can have AKI. It may not even have anything to do with intrinsic renal disease or hepatorenal syndrome. It can be something as straightforward as compartment syndrome, and we just have to keep these things in mind. So a renal ultrasound with Doppler can actually help us if we measure the resistive indices in these kidneys, and I'll go over that in a bit. And the different types of AKI, you can have a bunch of different kidney injuries on top of HRS. You can have CKD with HRS, and that's really what makes these cases challenging because we can't figure out if there's more than one source of kidney injury. It's hard to figure out and pinpoint what it is that's going on. And that's where, again, that's another place where research is kind of going on to differentiate when it's AKI from other places or when it's AKI from hepatorenal syndrome. So that leads us to biomarkers of renal function. So something that's kind of been looked at is this protein called NGAL. It's neutrophil gelatinase associated lipocalin. It's a big word. Essentially, it's been shown that it's higher in patients who have cirrhosis and ATN versus patients who have prerenal AKI or HRS. So a value of, I believe it was 176 or something close to that. If it's higher than that, you're more confident that it's probably ATN that's causing this kidney dysfunction. And if it's lower than that, you're thinking AKI from prerenal diseases or HRS. So things like this are consistently coming out, and there's not huge studies going on this, but in the future, this is where we're kind of headed. The other thing is serum metabolomic profiling, and this just includes a bunch of different proteins and metabolites that, again, that are increased as the severity of liver disease increases. So you can really see how far along they are in their liver disease and even in kidney dysfunction by evaluating some of these metabolites. Again, not part of any guidelines yet, but this is kind of where we're heading. And this is hopefully going to help us as more research goes into this. So this is what I meant when I said a renal ultrasound with Doppler can help us. And the hallmark of hepatorenal syndrome, as we described, which is like the end-stage cirrhosis with kidney dysfunction, is really cortical ischemia in the kidneys. In the beginning of cirrhosis, we start seeing vasoconstriction going on in the main arteries coming into the kidney, the main renal artery, but we still see the cortical arteries doing fine. And that's where this comes from. This is when you have essentially no ascites. Essentially, this explained in a simpler way, this restrictive index is really how much vasoconstriction you have going on, right? So interlobar, which is around here, minus the cortical restrictive indices, which is here, if there's a huge gap, you're still at the beginning of your cirrhosis and AKI. Huge gap means that this artery is very vasoconstricted and this artery is not. So the cortical arteries are still somewhat intact. As you progress through your cirrhosis, as you progress into more renal failure, we see this gap really start to close because now there's a homogeneous spread of this vasoconstriction all over the kidney. And really, that gap closes, and you have diuretic refractory ascites, and that's really when you start seeing the full-blown hepatorenal syndrome. So the hallmark of hepatorenal syndrome essentially being the cortical vasoconstriction that goes on up here in the kidney. So how does the body and how does the kidney compensate for this kidney? So really, we know that the afferent arteriole has prostaglandins that can help dilate this artery, and we have angiotensin II and other vasoconstrictors that can vasoconstrict this efferent arteriole. All of this is to keep the GFR consistent. So normal healthy kidneys do this on a regular basis, and cirrhotic patients, they start doing this to compensate for the reduced plasma flow. So obviously, because of the vasoconstriction, whether it's in the main renal artery or up until the cortical arteries, you have reduced plasma flow to the kidneys. So the kidney has to increase the filtration fraction. And by the filtration fraction is really increased by this dilatation of the afferent arteriole and the vasoconstriction of the efferent arteriole so that the pressure in the glomerulus stays the same. As kidney injury progresses, as the cirrhosis progresses, the kidney is not able to keep up with this much level of reduced plasma flow, and therefore your GFR now just starts dropping. Okay, that can drop. Obviously, that can drop over time, which is what we see in CKD, hepatorenal CKD, or AKI, which really can be acute. Now, this also points out to the fact that we want to make sure these patients that should not usually be on any ACE inhibitors, any ARBs, or any NSAIDs, because all these things, so ACE and ARBs obviously will inhibit this angiotensin and stop this filtration fraction from going up, therefore really stop the compensatory mechanisms that are going on in the kidney to keep that GFR at the same level. And the same is true for NSAIDs and other nephrotoxic agents with their effect on these prostaglandins. So, we have to obviously review the medications that the patients come in with, and hopefully, this is part of the reason why they can improve their AKI if you just take off some of these offending medications. So now we get to kind of how this forms. How does hepatorenal syndrome happen? And we know that we see low systemic vascular resistance in these patients. right? Their blood pressure is low. They have otherwise very low systemic vascular resistance. But I just stopped talking about so much vasoconstriction going on in the kidney. So how does that happen? Well, the real reason is you have such a huge burden of splanchnic arterial vasodilation dilation going on in these patients. And that really, the vasoconstriction goes on everywhere else in the body, and that's still not enough to kind of tip the scales in terms of the total systemic vascular resistance. And that's why you see the total systemic vascular resistance actually be much lower in these patients. That's really what we're trying to fix. So this is such a huge burden. I remember in a talk I heard in my last year of residency, we got shown a nuclear scan of patients kind of before this hepatorenal syndrome in cirrhotics and after. And the before, you still saw the kidneys and you still saw a good amount of blood flow in the thoracic area. And after, you could barely make out the kidneys. You just saw this like pool of blood, this dark area in the splanchnic region. The thoracic area was much lighter. You can't see the kidneys. And you can kind of see that, all this vasodilation in splanchnic area is one thing, but the other part of it is this vasoconstriction that really goes on everywhere else. It goes on in the brain. So the encephalopathy we see in cirrhotics is not always due to ammonia. You can have a relatively normal or low level of ammonia. It's also partly due to the ischemia that goes on from this vasoconstriction in hepatorenal syndrome, because your body is just trying to maintain your vascular resistance. Same thing with the kidneys, we see AKI, and same thing with the heart, which we'll talk about in a second. So the prevailing theory of how this splanchnic vasodilation happens, right? If that is the main cause of all this because of portal hypertension, how does this happen? Well, we think that all starts with the bacteria in our gut. The bacteria, because of the permeable capillaries through this portal hypertension, allow the bacteria to really translocate to these mesenteric lymph nodes, and they release basically these vasodilatory enzymes and markers and cytokines that all kind of vasodilate on a local area. So they, all over the splanchnic bed, this happens. And that's why you see such a profound increase in nitric oxide in these patients, in specifically the splanchnic area. And all this vasodilation is so huge now that it really starts to burden the body in terms of how it starts to compensate. So bacteria translocate down, they release all these cytokines. Now this doesn't necessarily mean that they have sepsis. This is just a localized vasodilation that goes on in all of these arterial vasculature all over the splanchnic area. All right, so how does this affect the heart? Well, we just talked about total systemic vascular resistance going down, and we just talked about how there's so much vasodilation going on in the splanchnic area. And we talked about how there's vasoconstriction in the kidneys. Well, what does that mean? One, the vasoconstriction in the kidney means there's so much upward regulation of the RAS system, the renin-angiotensin system, to make sure that the heart pumps more blood to the kidneys. And there's huge activation of the sympathetic nervous system. Your catecholamines are surging in these patients. In cirrhotic patients, you have high cardiac output. You always start with a high cardiac output because your heart has to make up the pressure from all this low systemic vascular resistance in the splanchnic bed. So this is what we call cirrhotic cardiomyopathy. Over time, the heart starts to get weak. And when we get to hepatorenal syndrome, when we get to these end-stage cirrhotic patients, your cardiac output actually starts to go down. And even if it's normal, it's not normal for these patients because you have so much other stuff going on, it's not enough to compensate for it. This unfortunately starts your whole spiral downwards because now you have your vasoconstriction in the kidneys activating the heart to pump more. You have the splanchnic vasodilation telling your heart to pump more. And you have activation of all these symptoms that really lead to this cirrhotic cardiomyopathy. So although we call it hepatorenal syndrome, we can't forget the role the cardiovascular system and specifically the heart plays in all this because that's really what's providing the blood flow to all of the body. I really like this whole graph because this essentially sums up where we are now in terms of our thinking on how this happens. Damaged hepatocytes essentially release inflammatory markers, and the bacteria that we just talked about that translocate lead to this vasodilation in the splanchnic area. And this all is in the setting of portal hypertension from cirrhosis. So because of this vasodilation, we have a decrease in systemic vascular resistance, and you have these activation of these profound vasoconstrictive factors. The RAS system, the sympathetic nervous system, the vasopressin is all very elevated as we progress to hepatorenal syndrome, which makes the heart really work faster and kind of going into this heart failure where you start having this decreased cardiac output. It further leads to a decrease in your renal blood flow, further causing a decrease in your GFR, and really that's when you start seeing this kidney injury just progressing, okay? Now, one last thing, this kidney, so this is the overall pathophysiology. So in an otherwise cirrhotic patient who's progressing, this is the picture we might see in HRS CKD type, right? Over each successive visit to the physician, you may see that creatinine creep up from that 0.4, 0.5, and every time it's a little bit higher. And this is really what's happening. Sometimes it's an inciting event that causes just an abrupt change in their kidney injury, and that may be something as simple as an infection, sepsis, or volume loss. And that's when you see the hepatorenal AKI type, hepatorenal syndrome AKI. Okay. Bilirubin and hepatorenal syndrome. So we talked about it a little bit before, how we measure creatinine, how if you have high levels of bilirubin, you're not going to measure creatinine accurately. Well, the other thing is sometimes you also have intrinsic kidney disease called by, we call it bile cast nephropathy, which happens in a subset of these patients, that if your total bilirubin is above 10 or 15, you can get some tubular obstruction. So that just goes on to say how muddy these waters can be, because now you're adding on essentially an ATN cause on top of this low blood flow to the kidney and just potentiating the kidney injury. All right. So we went over what happens. We kind of understand what's going on. So that's where the treatments come in. Our goal is to vasoconstrict the splanchnic bed. That's really the cause of all this. So it starts with portal hypertension, causing splanchnic vasodilation. And then we're hoping that if we vasoconstrict that area, we don't have this intense release of catecholamines. We don't have this intense activation of the RAS system. And we start all this by giving albumin. So we talked about before how obviously in 1995 when they used saline, now we used albumin. Well, albumin already is better in cirrhotic patients, one, because they have hyponatremia, and these patients usually have ascites. So giving them saline is not going to help much. Not only is it probably going to decrease their sodium, it's going to cause a worsening of their ascites. So albumin already helps with that because it's another way to expand the intravascular volume. But really, it's really cool that we've used this as also our treatment method because it reduces the vasodilator compounds in our body, specifically the splanchnic area. So we've shown that albumin not only fixes the hyponatremia in these patients, but can already reverse hepatorenal syndrome for even happening or at the beginning stages of hepatorenal syndrome. So really, this is the crux of our treatment and our testing of if they're even gonna need other forms of treatment. Terlipressin across the globe, really, except in the United States and Canada, is what the first-line therapy is. And this is a vasopressin analog. We don't have it available in the United States, not yet. I believe there's a couple studies going on to try to make it available. And that's really because the other drugs we use, again, we want to vasoconstrict. Alpha agonist plus a creatide. They've really not shown any difference, right? The studies that have been done, the differences were associated with the different drug dosing. But overall, all these three things, the main point is to vasoconstrict. So midodrine plus a creatide, obviously, if you are not in ICU because you don't have to give anything IV, and noradrenaline or norepinephrine if you're in the ICU setting. How do we get to a creatide? It's a somatostatin analog. The other thing we notice in cirrhotic patients as cirrhosis progresses is these really high levels of glucagon, which functions as a vasodilator and activator of these cytokines. So somatostatin actually, and octreotide, they actually decrease those levels of glucagon on top of other vasodilatory compounds. So then you help with that vasoconstriction effort along with the midodrine. So this is just the dosage, so straightforward. We can use midodrine or creatine, so this is PO, this is sub-Q, norepinephrine in the ICU. All of this usually needs to be given with albumin. Now, we obviously start with this trial of volume expansion for 2 days, 1 gram per kilogram we usually use, but they need to have continuous albumin of some sort for the treatment duration. And the treatment duration in all these patients is at least 2 weeks. So you're rarely going to see such a quick reversal of this kidney injury. You have to like treat them for at least 2 weeks to kind of see if your treatment is even working. The other thing is we want to target a mean arterial pressure. We want to target an increase of at least 10 when we're talking about on the floors, or 15 when we're talking about the ICU, is because if you don't increase it by that much, these patients really have not shown any benefit. So not only do you treat them for 2 weeks, you have to target, so you have to titrate these medications, you have to try to target a mean arterial pressure and increase that by at least 10 or 15 to see some sort of benefit. So it's not an easy thing. And it's not an easy thing because lastly, even all of this can sometimes fail, right? The full-on treatment for this is liver transplantation. Just a few quick points before we finish. TIPS. So what's the role of TIPS in all of this? Well, TIPS is good, but by the time they have hepatorenal syndrome, they already have such profound liver failure that it's already a contraindication to the TIPS. However, in patients that have received the TIPS procedure, they don't tend to develop hepatorenal syndrome as much. And that really, kind of goes on to tell us that it's really the portal hypertension that starts all of this cascade. It's really the portal hypertension that if we kind of control that, we're really decreasing the risk of hepatorenal syndrome. Renal replacement therapy, that's obviously on a case-by-case basis. It really doesn't help with longevity unless you're maybe considering a liver transplantation. So it has to be on a case-by-case basis, and we have to make sure that it's not affecting the quality of life of these patients and it's not futile. So it really has to be a discussion with all the physicians involved and the patient. Last thing that's really undergoing a lot of research is the molecular absorbent recirculating system, or MARS, which is essentially a dialysis for the liver. And that's shown some benefit, especially in the acute form of HRS. So I think this is the last slide. At the end of it all, our goal is to vasoconstrict these patients. But really the treatment, as we know, is liver transplantation. This graph shows the simultaneous liver and kidney transplantations that have taken place over the course of the years, and we can see that it's really increasing, and this starts at 2002. And again, that's because we're not really sure how much of the kidney is going to improve. So the nephrologists really have to be careful about the transplant nephrology has to be careful about when do we pull the trigger for the simultaneous transplant versus not. There have been cases where the native kidney starts perfusing well after their transplant, and now you have like 3 different kidneys that are working, so that's great, but that kidney could have been used somewhere else, and vice versa. Over the course of all this, they usually say 6 weeks. If the kidney injury has occurred for about 6 weeks, that's probably the time to pull the trigger on simultaneous transplant. So obviously, these are things that we need to think about when we refer these patients. And really help in quality of life. How prevalent is hepatorenal syndrome? Well, there's so many different studies with so much variability. We know that there's definitely a subset of patients that develops them. It's not as much as previously studied, but it's definitely a good percentage, 3 to 5, 15%. 15% over the course of all cirrhotic patients usually will develop some sort of hepatorenal syndrome. And again, we need more studies for this, and the most important thing is because of how bad of a diagnosis this is, because of the really mortality and the morbidity it causes, we need to kind of be on top of this or always have it in the back of our mind, as it may not be the only diagnosis, but it may be something we need to look for. So I think I've gone on for quite enough time. In summary, hepatorenal syndrome now has a revised criteria, And it's really based around understanding what the GFR is in these patients. We now call it hepatorenal syndrome type AKI and type CKD. It's obviously potentially reversible, so we want to find it early enough so we can fix it early enough. The goal is really to oppose this profound splanchnic vasodilation, and the optimal treatment really is transplantation. And there's ongoing research in this. So I hope you guys enjoyed it or learned something. Thank you.
Thanks a lot. I had a question for you. Obviously this is a very expensive diagnosis, right? If somebody, even if somebody has hepatorenal syndrome, they're looking at 2 weeks of octreotide and midodrine minimum plus albumin or liver transplant. So the question is, what should we be doing to prevent people from getting hepatorenal syndrome?
The main thing, again, from all the reading that I've come across is identifying when their renal function really starts to drop. And that really, I think, starts more on the outpatient setting even. So understanding what their baseline creatinine is, as we were going over, if you start to see, again, these patients have such a low level of creatinine at normal levels that we usually just attribute it to, okay, we'll just follow it up, And it can be as low as 0.4, 0.7, and they still have some sort of renal injury. So if we identify that faster and we already try to take away nephrotoxic drugs or add albumin, you don't ever have to even go through this treatment. So that's the benefit.
I think that's the main thing probably, is being careful with diuretics.
Yep.
Because they run right on a razor's edge, and being liberal with albumin. Are there any other questions? Or
So I've seen a surprising lot of what suspected hepatorenal syndrome. And I know a lot of times it's still in-house really hard to decide if it's pre-renal, and it looks a lot the same. But what I have noticed is that they said the treatment's 2 weeks. A lot of times we do see response with that creatine and midodrine after a week or so, and we tend to taper down the therapy or stop the therapy if their blood pressure is maintained.
Right.
Is that the standard that you should absolutely treat for 2 weeks regardless of response?
No, not regardless. But most patients, they need at least that much to keep their MAP elevated that high. But the main thing here is we shouldn't just stop treatment because they're responding a little better. We need to be aware of what their mean arterial pressure is during that time.
any other questions?
Is there any recommendation to have these patients referred sooner to for transplant? Is that part of?
So all these patients, so the question was if they should be referred sooner to transplant. And really, again, if we identify this faster and we're starting to treat it faster, that's around the time when you have a concrete feeling in your mind that this is a hepatorenal syndrome. Yes, we should think about transplantation at that point. It's never too late, it's never too early to start thinking about transplant because it does take time. And I think that goes across all other fields. Whenever you're considering transplants, it's never too early to start thinking about that.
Yeah, I think as a general rule, flying somebody in extremis to a transplant center is a bad thing. So the sooner we think about it, and at least begin the dialogue. My experience with transplant centers is they always have a little initial pushback. So the sooner you make the initial contact with them, that second and third call can happen so that patient can get there. And that way, if they don't respond to therapy, right, you don't know. So I would, if I made a diagnosis of hepatorenal syndrome, I think it's perfectly appropriate to contact the transplant center if the patient's otherwise a transplant candidate.
If they're still drinking?
Right.
Yeah, and so most transplant centers don't transplant actively drinking people. Most of them want 6 months of out of hospital sobriety, although there's some data that for otherwise salvageable people with good support systems who say that they're going to quit drinking, that they actually do quit drinking. So there are some transplant centers that don't feel it's ethical to give up on those folks. But I think to me the biggest issues are what are the comorbidities. Most transplant centers will not transplant an active cigarette smoker now because they have a very high incidence of cancer post-transplant because of the immune suppressives. I think that financial considerations are always, nobody likes to talk about it, but
And terlipressin, which is used everywhere else, is actually cheaper than the other drugs. I don't know if it happens in the United States. When it does, it's going to be as expensive. But yeah.
Thank you.
Thank you.